And it's my pleasure to introduce Dr. Wen Fan Hu, who will lead off today's grand rounds. Wen is an assistant professor of ophthalmology and part of our uveitis service, where she splits her clinical time between treating both adults and children with uveitis. In addition, she has a growing cataract practice where she performs complex surgeries on patients who may suffer from inflammatory eye disease. She received her medical training at Harvard University, where she also completed PhD in neuroscience, and she remained at Harvard to complete her residency in ophthalmology and went on to complete a fellowship in uveitis at Moran Eye Center as a lead ophthalmic fellow. Wen's research interests include improving the diagnosis of infectious and malignant uveitis and improving outcomes in patients with uveitis undergoing cataract surgery. She's already received career development funding from the National Institutes for Health for her research, and she's co-PI on 2 new uveitis clinical trials. The first clinical trials in uveitis at our growing eye institute. So congratulations, Wen and Amde, on getting those trials here. Besides her clinical and research efforts, Wen is very involved in education as associate director of our residency program and is leading the project team to revitalize the resident surgical training lab, where she has helped to secure over $1 million in philanthropy to support this renovation. Please give her a warm welcome as she presents the Flaum Eye Institute Urgent Eye Care Clinic.
I just wanted to, while we get Dr. Hu's presentation up here, ask the folks out in the audience, if your name is iPhone, try renaming yourself, because I can't give CME credit to iPhone.
Great. Thank you, Dave, for that kind introduction. I'm excited to share with you all today our experience transforming the former resident continuity clinic into the new urgent eye care clinic. And before we talk about what exactly that transformation entails, I think we actually need to back up a little bit and talk about what is a resident clinic, how are residents trained, and then talk about why some of these changes were made. So becoming a fully trained physician is actually more complicated than just graduating from medical school, as many of you know, that even though you finish medical school and you get your MD degree, there is actually postgraduate training that happens before you can become fully credentialed and, fully trained. And so that usually involves residency, which first year of residency is considered internship, and then anywhere from usually 3 to 7 years, depending on your specialty. For ophthalmology, that's 4. And after 4 years of ophthalmology residency, you're fully trained as a general ophthalmologist. Many people go on to pursue additional subspecialty training in retina, plastics, glaucoma, and that fellowship then allows you to practice even more of subspecialty care. So how do we ensure that somebody gets from, brand new graduate from medical school to a fully competent ophthalmologist? So that is the responsibility of the ACGME, so the Accreditation Council for Graduate Medical Education. They oversee all residency programs and all specialties, including ophthalmology. And there are specific domains that every trainee or every resident is required to meet. And these are in domains of patient care, which includes things like exam skills and diagnostics, medical knowledge, your knowledge of treatment, pathophysiology, systems-based practice, your knowledge of and involvement in patient safety or quality improvement, evidence-based learning, professionalism, which includes, conscientiousness and ethics, as well as interpersonal communication skills with patients, family, colleagues within the healthcare system, including the electronic medical record, for example. And there are benchmarks. So I'm just giving you an example here within ophthalmology. Under patient care data acquisition, there are benchmarks for what is considered level 1 skills versus level 5 skills. And the idea is that as you progress through training, you develop your skills and you progress through these levels. The goal is usually it usually tracks with your PGY year, so postgraduate year, and that by the end of residency, you should be at least at minimum at a level 4 across most of all these domains, and there are 20 total domains. So this is very standardized, but in practice, how does that actually happen? How do you get from this person on the left to the person on the right? And I would think of medicine, I think, a little bit as an apprenticeship model, right? That as you become more knowledgeable and you're more trained there, you develop more autonomy, more decision-making power, and that there's sort of a lot of oversight for you at the beginning of your training and maybe less oversight at the end. And there are sort of two ways that this can develop, sort of two classic models. There's what is considered the attending clinic, attending physician model, where a patient comes in and they're scheduled to see the attending physician, the fully trained ophthalmologist. And that person, because they're in a teaching institution, is working with trainees. And so they have a host of maybe residents who are rotating through in their clinic, and the residents are learning, but the patient is coming back on a visit by visit basis to see the attending physician, and they may see different residents coming through. And for residents, the advantage here is that you're learning from somebody who's subspecialized in that specific area of expertise. For patients, they're having continuity with that specialist. And then the residents are learning more on a point by point encounter. So maybe not seeing the same patient over the course of their disease, but seeing different patients with similar diseases across that time period. Another model is called the resident clinic model. And so the resident is actually the main physician that a patient comes in and sees. The idea is that the resident, because the resident is now the physician, they develop and they have continuity with this patient, and they are seeing that same patient and that disease over the course of that entire disease, over the course of their residency training. Obviously, these residents are still supervised, and so there are attending physicians that supervise in resident clinic, but in general, that attending physician is probably not as consistent as in the other model. So as a patient, you would come in, you would see doctor resident, but that you might see a different attending supervising physician each time. And I think both of these models have advantages and disadvantages, and it's always a balance between resident education, autonomy, and training versus patient care and health equity. And so I'll share with you some of our experience. So what is the landscape, just in general, across US ophthalmology residency programs? This is a survey from 2017 now, where they were able to capture over 90% of US ophthalmology residency programs in the US. And you can see that 70% of residency programs had some form of a resident clinic, 30% did not. And of those 70% that did have a resident clinic, it was fairly evenly split. So there were requirements in about a third of them for the faculty member to see and examine every single patient. A third of the programs, the faculty member was required to discuss, but not necessarily examine every patient. And then there was a proportion where there was no requirements stated for faculty supervision. And these programs with resident clinics, you can see they're more likely to be in urban settings. They're more likely to be at referral centers. And so this is the structure that was at Flaum Institute prior to 2022 in these changes. So if we exclude sort of the COVID years and you look at what our residency training program here looked like, this is just based on time. Residents were spending 60% of their time in resident clinic, and there were various subspecialty clinics within that resident clinic. About 30% of the time in, quote, faculty practice. And so that's where the patients are coming in to see the faculty member and the residents are rotating through. And then a small percentage of the time on hospital consults and on research. But we know that resident clinic, so in an ideal world, the patients that are seen in resident clinic are reflective of the patients seen at your institution at large. And so they're just a subset of patients where the residents are learning, and they should represent the patient population that the institution is taking care of. But we know that resident clinic differs from the average population by various forces that we can talk about. And I'm sure Dr. Elam will share with us later. This is data from UPMC and Mass General Hospital, big teaching institutions where they looked at, hundreds of thousands of patients seen in resident clinic. This is from internal medicine. And you can see that patients seen in resident clinic as a resident, primary care provider, they're more likely to be underrepresented minorities. They're more likely to be non-English speaking. They're more likely to have Medicaid, which is governmental insurance for patients of low income. They're more likely to be living in poverty. They're less likely to be educated, and they're more likely to have other medical comorbidities and more likely to be just sicker in general. And we also know, this is data out of Boston, also from internal medicine, that clinical outcomes in resident clinics are worse. So looking at just, basic medical control, medical primary care, A1C control, blood pressure control, the control for patients who are seeing primarily a resident provider is worse than seeing a faculty provider. So it's in the light of this data and this experience that in 2022, the Flaum Institute dissolved the residency continuity clinic, and I'll show you more data comparing before and after. All patients that used to be seen in this resident continuity clinic were reassigned to faculty providers according to their medical problems. The residents were then reassigned into 3-month subspecialty rotations, all within the faculty practice. And at the same time, an urgent eye care clinic was established to provide same-day access to acute disease care. Residents continue to rotate through this urgent eye care clinic, and they are supervised by board-certified ophthalmologists. And so this is what the current resident curriculum now looks like. So almost 75% of the time, residents over the course of their residency are now within faculty practice, about 15% of the time in urgent eye clinic and similar amounts of time on hospital consults and research. And you can see that within that faculty practice, there's a nice spread in terms of the various subspecialties that the residents are getting to experience and learn from. And so we took a look at sort of data from four cohorts. So we looked pre these changes, and we looked specifically before COVID because 2020 sort of threw a wrench in everything. So we looked at patients that were seen in resident clinic from 2017 to 2019 versus patients that were seen in faculty practice during that time. We also then looked at the past 2 years after these changes were implemented, patients that were seen in urgent eye care clinic versus the faculty practice, which now includes everybody. You can see the number of patients. This is, over 80,000 total patients seen at Flaum with over 400,000 total clinical visits that we've had. And so let's talk about the impact on patient care and health disparities. So all the graphs I show you are going to show resident clinic on the far left, the faculty practice previously next to that. And you can see just by insurance payer that there was a huge overrepresentation of patients on Medicaid who were seen in the resident clinic. Medicaid, just to remind you all, is governmental health insurance for patients with low income. And so you have to meet certain governmental criteria, 56% compared to 16%. After the change, you can see that there's more similarity, that the urgent eye care clinic more resembles the sort of overall patient population that's seen in faculty practice, although we know that there will be some changes, right? People who come in for acute issues are not necessarily the same people who have chronic issues that need to be seen regularly. If you look at racial demographics, this is patient self-reported race. You can see that in resident clinic, there was a large proportion of Black African-American patients, as well as multiracial, Native American, and other, as opposed to faculty practice, which was very heavily predominantly white and Caucasian. And after the changes, that has stabilized out and become more similar between the two groups. If you look at patients who are non-English speaking and required interpretation services, you can see that was very heavily overrepresented in resident clinic as well compared to the faculty practice. And now that's similar between the urgent eye clinic and faculty practice. And Chris shared with you, screening tools that are available in Epic now to screen for food insecurity, for housing insecurity, for transportation needs. And so we were able to pull that data, and you can see that there was a big difference between resident clinic and faculty practice previously. There is still a difference actually between patients seen in urgent eye care clinic and the faculty practice now in terms of food insecurity, although it's much smaller. Same is true for patients who are at high risk of housing instability, patient with unmet transportation needs that are impacting their ability to get healthcare. And so, I think the argument historically for resident continuity clinic is that training is better if there's continuity. And so we specifically looked at, is there continuity in resident continuity clinic? And we looked in sort of two different ways. One is with a continuity score. And so we looked at patients who had greater than 2 visits at any point to Flaum Eye Institute within that time period. And we looked at we took their total number of visits, and we looked at how many visits did they have with one provider, and that we chose their most frequent provider. And so in an ideal world, if you have 100% continuity, your score is 1. You're seeing the same person for all of your visits. If you are seeing, 50-50, your score is 0.5. And then if you have no continuity, you get close to 0. And so this is a histogram of the continuity score. And you can see this is in faculty practice in 2017 to 2019. And the vast majority of patients, at least 3/4 of their appointments are with the same provider, which is great. This is what it looks like for resident clinic. So vast majority of patients, less than half of their visits are with the same person. And this, if you look at the attending physician of record, that is similar. So there's really no continuity in resident continuity clinic. Another way that you can take a look at this is we plotted the number of appointments per patient against the number of total providers that they saw. And so every dot here represents a different patient, and the bigger the dot, the more patients there are. So this is in the faculty practice, and you can see the vast majority of people, have a small number of visits with a small number of providers. But, as you go up, there are patients, this actually goes out to like 90, but there are patients who have lots of appointments. And based on this slope, what this tells us is that for about every 10 visits a patient has in faculty practice, they see 1 additional new provider. This is what it looked like for resident clinic. So take a look at that slope. That's telling us that for basically every 2 visits a patient had to resident clinic, they were seeing a new resident provider. And for the faculty preceptor, it was maybe a little bit better, but still every 4 visits to resident clinic, they were seeing a new faculty provider. So after the transition, what does it look like? All those patients were rolled into faculty practice, and lo and behold, now patients are having better continuity of care. So this now more closely resembles that of faculty practice previously. We're looking now at about 8 visits. So 8 visits for a patient before they see a different provider. And I think strikingly, the no-show rate improved for a lot of these patients. And so if you look at the no-show rate in resident clinic, we were up at 23%. Faculty practice was 8%. After the change, actually, which now includes all of Flaum Eye Institute, that no-show rate dropped even further. So it's now 6%. So I think, overall, this transition has been great for patient care and for health disparities. I think the question now is, what was the impact on resident education? So as you might expect, higher acuity disease presents now more frequently to urgent eye care clinic compared to resident clinic. And we took a look at this just by follow-up time. So high acuity being any patient that was required to follow up or did follow up within a week versus a month versus greater than a month. And there's a much higher proportion of high acuity patients. There's also more diverse disease pathology. So we kind of know what the disease pathology is that patients or residents are seeing with faculty. If we look at what are they actually seeing in the urgent eye clinic, which does comprise, about 1/8 of their time, you can see that there's a bigger spread in distribution. They're seeing, for example, more cornea, more oculoplastics, more uveitis there, was a little decline in retina. There was a big decline in glaucoma, presumably because more of glaucoma is more longitudinal care. We also looked at sort of disease etiology, and there's more inflammatory disease, more traumatic disease, more infectious disease that was seen in the urgent eye clinic as well, which you might expect for sort of an urgent care type of situation. And then I think the big question is, what was the impact on surgical experience for residents? So the same survey of all US ophthalmology residency programs, about 3/4 of the programs tracked their surgical volume from resident clinic. And you can see in the vast majority of those, the resident clinic accounted for 50% or more of the surgical experience for residents. So specifically looking at cataract surgeries. And so fortunately for us, when we looked at our surgical numbers remained stable or even improved in certain areas. So 2017 to 2019 is in the blue bars, 2022 to 2023 is in the purple bars. The 2024 data has been submitted to the ACGME, but hasn't been formally processed to fit into the same category. So we have some preliminary data for that. And then I also included sort of the 2 years post-COVID, just to give you a sense of what the trajectory was. Procedural and surgical, procedural experience and laser experience also either remains similar or improved. And so in summary, I hope I've shown you that the resident clinic highlighted some structural disparities that we had in delivering ophthalmologic care here at Flaum, which prompted this transformation from resident clinic into an urgent eye care clinic. And that transformation reduced those socioeconomic disparities. It improved continuity of care for all our patients. It improved access to care for higher acuity disease, and that it improved the breadth of resident clinical exposure and maintained or improved surgical and procedural experience. So with that, I'll take any questions.
That was a great one. Thanks very much. We're actually having a symposium on this at the this coming up, so it should be exciting to talk about it. One thing that we've discovered is that not one size fits all program. So do you have a county hospital? Do you have a VA? What is your system that you're working in? So I don't know what you have in Michigan. So what do you guys have, and how have you looked at this problem?
Yeah, we don't have a resident clinic. We now have an urgent clinic, but it's run by an attending who no longer wanted to operate, and she just said, "I'll staff an urgent clinic." But the comprehensive clinic, I guess, it's not called the resident clinic, but it's where they spend a lot of time. But there are attendings there. There are attending patients who the residents, kind of take ownership of. So I don't think Kellogg has ever had a resident clinic per se, a resident run clinic. But I just love that you all even thought to do this. I know this is, resident clinics have been a thing in so many places for such a long time. And so it's just so impressive. And I know it's a big overhaul to do, so that you all have done it really.
Awesome.
So before we did change over the general clinic, but the year before this data, we had the subspecialty clinics. All those subspecialty resident clinics merged into the faculty practice. So that was actually the first year that we did. And then we took on the comprehensive continuity clinic.
Yeah.
So it was a stepwise approach. It helped a little bit. But how do you guys deal with handing over cases, cataracts and trabs and stuff like that to residents?
It depends on the subspecialty. So in comp clinic, it's easy because the residents it's their home, even though it's not resident run. So, any cataracts that come, they're the ones who explain the consent. And even though they're attending patients, the residents do those cases, and all of the attendings are on board with that. In the subspecialties, we have a little bit of a problem, at least on our evaluation from the residents. We are not handing over cases enough. And so even though the comp clinic is not called resident clinic, and to some degree, it operates in that way because residents take much more ownership. And in our subspecialty clinics, we, as attendings, need to do a better job of handing over those cases. So how do we do it? Probably not very well in our subspecialty.
You can't trust the
but-
residents. I can give Dr. Joshi 200 injections and she still tells me she doesn't have enough injections.
No, but I'm just so impressed by this. One question I did have, well, my first question as I was listening to the presentation was, how smoothly did this go? But I was like, oh, that's gossipy. I don't want to, that's not a good question. But I am interested to know. So yes, from a health equity standpoint, this is amazing and really good for patients. And the surgical numbers thankfully are stable. But as far as we're chatting during lunch about continuity, as far as, for example, the decline in glaucoma patients. So it's like, you come in with this high pressure, but then for the next 3 years, what is done? And so I'm interested to know how you guys are balancing that loss of continuity from a learning perspective for the residents with the balancing of the excellent changes for health equity.
I think that is sort of the final question, right? Is there is value to following that same patient and watching the disease evolve over time. How can you do that in a faculty practice? I think, Rachel and I have talked about this. I think longer rotations with more consistent faculty members. We've really tried to keep the residents with a small cohort of faculty members and trying to have them be consistent so that you increase the chances that you're seeing the same patient over time. I think, there's a little bit of, ownership that residents have to do in terms of chart stocking, even if you're not seeing the same patient, maybe you see them in the urgent eye clinic and you follow through and see, okay, what did the attending think? What did they do? And okay, how are they doing now a month out? I think that probably that is something that we have to build in maybe in order for residents to learn more about to have that continuity, even if it's not continuity seeing the same patient, but at least continuity of that patient's disease.
Yeah, my take is no matter what system you choose, you're going to sacrifice something on something. But let's not lose sight of the patient here in all of this, right? Let's try to keep the patient-centered care and then make our decision tree and decide what the sacrifice is. I just feel like in this old system, and you can saw what our continuity numbers were, they weren't good. We had a smaller residency program. The residents were pulled back and forth. There's vacations, they come out, this, that, and the other thing. So if we really didn't have a strong continuity clinic, that was something we could say, well, we're really not losing out because we haven't been doing that well anyway. So that again, it's not one size fits all, and you have to look at your own program, make these evaluations, and decide kind of how you want to progress forward. In a program that has great continuity, it's totally different. It's probably a much more difficult decision.
Yeah, no, just to follow up on that, I think the reality is our continuity was abysmal, in our continuity clinic, and it was really just not possible for us to figure out a way for our patients to see the same, resident at each time. And I don't have numbers on this, but I would say anecdotally feedback I'm getting from residents that they're seeing more continuity in the faculty practice with these 3-month rotations. It is only 3 months, so it's not 3 years, but for the first time, we were actually getting feedback saying, hey, I was actually able to see this patient multiple times. And that was the first time we were getting that kind of feedback as a program. So I think to Dave's point, we can't do it all. I wish we could. And there's just so much for them to learn in such a short time that we can't give them that 3-year continuity necessarily. But I think we did actually make improvements. We're in a better place than we were a couple of years ago. But I just want to say too, just comment, Wen, thank you for putting numbers to what we knew in our gut was happening. And I think you need to put the data on the slides to really convince people. We tried to share a little bit of this data a few years ago at AUPO. to a less than enthusiastic crowd, I would say. But I think people are starting to kind of see this. So thank you for putting all this on the paper.
I have
It's
to say
awesome.
many thanks go to Sharon Ojo and Neil Dogler, who are medical students who are working with me on this, and Laura Wallace, who pulled and mined all of our e-record data, which turns out we had more than just Epic. There were many places where this data came from, and to Rachel and Dave for really spearheading this.
We found a Jim and Laura. I mean, she came on, she was like OAS and front, and all this, she had this incredible thirst for numbers, and we discovered that. She's been a great partner and she's helped with many of these projects. So. All right, Matt, did you have a quick comment?
Yeah, so I think that, continuity, I think has always been overrated. I think it's like this kind of thing. But even 3 years of, if you had the same patient for 3 years, most of our disease processes are chronic, aren't going to change that much in 3 years. Glaucoma is not diabetic or nothing, it's not going to change a whole lot. So I think it's more helpful as a teacher to say, we have, this patient for the last 20 years. Let's just go through 5 years ago, what is it? What is it 3 years ago? What is it now? I think that offers, with the single patient in a single spot, you have continuity by going back to the chart. Just throw that out. How to teach.
Absolutely. Absolutely. All right. Thank you very much, Len. I'm really pleased to welcome here today as our distinguished visiting professor. Dr. Liam is a assistant professor of ophthalmology at the University of Michigan Kellogg Eye Center, where she recently held the position of associate chair for diversity, equity, and inclusion. She's a glaucoma specialist by training, evaluating and treating patients with glaucoma and complex anterior segment disease. Her expertise spills over into advocacy and research in the field of health equity, where she has become an opinion leader. The resulting work related to increasing eye care utilization in Black Americans at high risk for glaucoma has been funded through an NEIK award. She's also a co-investigator on NEI and CDC grants looking at telemedicine and social determinants of health. Her efforts have resulted in nearly 70 peer-reviewed publications, abstracts, and book chapters and presentations, including the Roger P. Mason Lecture at Howard University. When not caring for patients and performing research, she's a vital member of the Kellogg teaching team, mentoring medical students, residents, and glaucoma fellows. Dr. Elam earned her undergraduate degrees at the University of Pittsburgh, followed by medical training at Duke, and she returned to Pitt to complete her ophthalmology residency, went on to Kellogg for her glaucoma training, and remains there as a faculty member. She's an active member of the American Glaucoma Society, AAO, Women in Ophthalmology, and ARVO. Please welcome Angela as she presents the journey to equity in glaucoma care. Just share it.
Oh, wait, I have to share it, right?
Yeah. Go back to Zoom. Yeah, click on Zoom. Yep.
Good. Thank you all so much for having me here. It's been lovely already, even though it's only been a few hours. What wonderful facilities, wonderful residents, faculty. I appreciate the invitation. And I would just like to say that it wasn't really me, it was my husband. It was my husband's fault, okay? That's why. My husband I couldn't even get him to move. So we live in Detroit and University of Michigan is in Ann Arbor, about 50 miles apart. I couldn't even get him to live in Northville, which is about halfway between. He's a pastor of a church in Detroit, and he felt very strongly that as the leader of the parishioners that he needed to live in the city with them. So no way I could go to Rochester. I couldn't even move to the suburbs. Always need to state our financial disclosure. So I don't have any commercial interests. I always like to acknowledge my grant funding sources. So before health equity was a thing that we acknowledge, I really, it was my motivation to become a physician in the first place. And it is what led me to be a glaucoma specialist. We were talking earlier about how I even came to become a glaucoma specialist or even an ophthalmologist, really. It wasn't because I was so in love with the eye or the day that we grossed the eye in the anatomy lab, I didn't even go as a first year resident. I'm a first year student. So I was like, that is gross. And here we are. So, but it really has been health equity and learning about the disparities that exist within the world of eye care that really motivated me to become an ophthalmologist and glaucoma specialist. But what is health equity? I think sometimes we get that confused with equality. And so a couple of years ago, Robert Wood Johnson Foundation put out this pictorial representation, which I think is really wonderful and also includes, low vision, which is cool. So equality is where everyone gets the same thing, regardless if it's needed or right for them. So you can see, there's the curve and the one gentleman does just fine with it. The little girl's about to break her leg. The lady with the wheelchair, the person with the wheelchair is not going to be able to cross the street. The gentleman with low vision, it's probably not safe for him to do so either. But when we're thinking about things from an equity standpoint, it's where everyone gets what they need. So we understand the barriers, the circumstances, the conditions in which people live and operate, and we respond accordingly. And so now there are visual cues, there's the ramp there. So everyone, nothing has been taken away from anyone, but everyone is able to now safely cross the street. And that is what equity looks like. So to get to health equity, we really have to start to address some of these disparities, which are these differences, health differences that affect marginalized or excluded groups. And we just can't get to health equity without addressing, identifying, and then eliminating some of these disparities. And so I don't know how many of you have read this paper, Why Do Some People Go Blind from Glaucoma? There's a QR code, feel free to check it out. It was one of the first, when I was in medical school, Dr. David Epstein was the chair, and he encouraged all of us students to read it. And my first day of glaucoma rotation, Dr. Joel Schumann's like, you have to read this paper before you can see any patients. And so, this was a paper written in the 80s. Some of you weren't even born yet. And it really was just, an observational paper. These authors have been taking care of glaucoma patients and noticed some things about patients and wrote about it. And that, in my mind, it may not have been the first paper, but that's where it starts for me. And so over the years, we went from that paper to more epidemiologic studies where we're really starting to see what the prevalence is, who has glaucoma, how does it affect people differently. And then we started to move into, okay, we know that there are differences in prevalence and incidence, but there's something more here. So we started to hear more about the treatment or utilization of care. Are there differences in the way that people are treated for glaucoma? And so at the University of Michigan, during my fellowship, we decided to contribute to that literature by exploring geographic variations in diagnostic testing for people with open angle glaucoma. So we looked at visual field testing, basically OCT, we called it other ocular imaging because at the time GDX was included, as well as fundus photos. And we looked to see for people who had a new diagnosis of glaucoma, how often did they get those three tests, visual field, OCT, and fundus photos. And you can see this map here represents the variation across the country. So if we look at the data in a different way, this turnip plot here, I just picked out a couple of places. You can see that down in Lafayette, Louisiana, they really loved their OCT. So most of the newly diagnosed patients were getting OCT. And mind you, this was years 2001 to 2014. In Ann Arbor, we weren't very excited about OCT just yet, and you guys were even less excited, it appears. With visual field, this is a similar map representing the geographic variation in visual fields. And again, with the turnip plot, now things are reversed. So in Ann Arbor, we really loved our visual fields. You guys did as well, but now Lafayette is way down, around 44%, I believe. And so the question was, why? Why does where you live, or why should where you live determine the type of glaucoma care that you receive? And so to follow that study, we looked at socioeconomic status using, so Medicaid insurance was the proxy that we used for socioeconomic status, because as was mentioned earlier, by definition, if you're on Medicaid, you have to meet certain income levels that vary by state, but all of them would be considered at or below the poverty line. So again, visual field OCT fundus photos, you can see in the sets of columns there across the board, Medicaid patients receive significantly less testing, all three testing, than those with commercial health insurance. And again, these were people with newly diagnosed glaucoma in the first 15 months after diagnosis. So we're telling you have glaucoma. It's been 15 months. Have you gotten the recommended test according to the AAO's preferred practice patterns? And the one that really stood out to us was that in that 15 months after being diagnosed with glaucoma, about half of Medicaid patients receive absolutely no testing, visual field OCT or fundus photo, compared to just 20% of commercial patients, which is also not good, but certainly staggering numbers. When we look at these data a different way, you can see again, overall that Medicaid patients had 244% increased odds of receiving no test despite new glaucoma diagnosis. And then when we stratified by race, that number increased to 313% in Black individuals with Medicaid. And so not only do we know that we know that racial and ethnic minorities are at greater risk of losing vision from glaucoma, but also people of lower socioeconomic status are not getting the same amount of utilization of care or treatment that others do. And we know that the way that race and socioeconomic status intersect in our country and in other places, that often leaves people who need care the most getting the least amount of care. And so it's been exciting over the last decade, I would say, to see that we've moved from thinking about who has glaucoma, disparities in care, to what are we going to do about it. And so I think these are exciting times. And these studies have been done all over Philadelphia, everywhere. And so again, we are trying our best to contribute to this space. And so back in 2021, we developed or designed the Combat Glaucoma Study, or community-based treatment for glaucoma, where we use community health workers. Community health workers have been used fairly extensively in other fields and in other parts of the world to serve as a bridge between physicians and the patient. We have not used that model very much in the eye care space, but it certainly has been promising in other fields. And so we're using community health workers and partnering with faith-based organizations in the beautiful city of Detroit, which is where I live. So again, community health workers have been used extensively in other fields, and this is a space where we can take a lot from global ophthalmology or international spaces, because they often aren't termed community health workers, but there are community members who are taught to check eye pressure, check vision, and really just serve as that bridge. And that is really a space where we can learn from our international partners. With regards to the faith-based aspect of things, faith for many people is really important. You may not be someone who goes to church or mosque or synagogue every weekend or several, even once a month, but that does remain pretty core importance for many people. And so we thought it might be helpful to tap in to that space. And that's been used again in other fields: diabetes, hypertension, heart disease, where they've been very successful in preventing disease or treating disease by tying in healthcare with faith. So from an NIH standpoint, you don't just start doing the work, you really have to make it sciencey. And so we used implementation science, which is a field that I really think is critical when it comes to designing and implementing studies. We're using implementation science and of course, community engaged methods to design this intervention, where initially our goal was really to just focus on education and addressing social determinants of health using the community health workers. The goal was to have this multi-level intervention and then to address some of the barriers that would be decreasing or keeping people from using eye care and therefore increase their eye care utilization. So we divided that aim or that goal into two separate sub-aims, where we used a TICD framework that's just a framework within implementation science to first identify the barriers and the facilitators. So basically go out into the community, sit down with community members and leaders and ask them, what is it that currently keeps you from seeing an eye doctor? And what are the things that we could do to create and implement this program that would make it easier for you to, or more likely for you to use or access eye care? And then the second part was to take that information and then design this program that would be community health delivered educational and coaching tool, what we thought we were gonna do, and then hopefully get that to encourage people to increase their eye care utilization. Excuse me. So for sub-aim 1, where we went out and identified those determinants of care, we found that all of the themes, so we took the data and divided them into themes, and we found that they all aligned very well with the 5 critical domains of social determinants of health, which was not surprising, but it was nice to see how they really did correlate. These 2 young ladies were really helpful in that study. So Dominique Alexis, the first young lady, is actually applying to ophthalmology this cycle. I hope she is on your interview list. She's a student at SUNY Upstate. She is absolutely fantastic. We can't get her to University of Michigan. She is a New Yorker and she is not coming to Michigan, but she will come here. So if she's not on your list, please add her. The other young lady is actually now a senior at Harvard. She's from Ann Arbor, but she spent the summer with us doing this work. So these are some of the themes that we found from our participants. Some of them are, we already know, we know about insurance, we know about cost, transportation, all of these things are things that we've heard about before. But trust is always one that really comes up time and time again when we're talking about healthcare and health equity and disparities. There are things that we can do as healthcare providers to try and address some of those things. Communication, how do we speak to our patients? How do we interact with them? The relationship that we have. A lot of this, I think we did these interviews back in 2022. So of course the COVID was still a topic of discussion. And these are just some of the examples. When you're dealing with qualitative research, we're often used to more quantitative things, and so we like numbers and such, but I really think there's such richness in qualitative data. And so just wanted to share some of the actual words of some of the participants with you. Fear is a thing. And, with the patient that we just spoke about, I mean, she was young, so maybe it's less about fear, maybe I don't know, but there's a fear of not wanting to know, not wanting to go to the doctor because you don't want to hear what they might have to say. It was interesting to hear patients talk about neglect from a governmental or like systems level approach, money being diverted elsewhere when there are all of these issues going on, and why isn't anyone talking about that? Again, trust is an issue, and prioritization. If you have all of these other competing factors, if you're unclear about how you're going to pay your rent or keep your car running, then maybe you don't go to the eye doctor. Same thing with facilitators. So we asked about barriers, and we also asked about the things that would make this program successful. And we measure success by, are you using the program, and does it increase your eye care utilization. Again, trusted environment comes up. And location proximity was certainly something that was high on people's list. The community health worker, people thought that was a wonderful idea because people still, there is this divide oftentimes between physicians and the patients, and having that bridge, I think, the idea of that seemed to be really welcome by people. Again, here are some of the voices of the participants. They felt that regardless of whether they are church members or not, that they would feel comfortable coming there. The particular church where we were is a church that already does a lot of health and social services in the community. And so it was a trusted entity. One of the difficult things about this type of research, implementation science, is when you ask the questions, you have to be ready to receive the answers. And so we just wanted to know what are the things that keep you from seeing the eye doctor, and what can we do to make our program work for you? And what they said is, oh, this, you're coaching and that sounds cute, but we want the care here. So we don't want to go, catch 2 buses and walk 3 blocks with my cane to get to, fill in the blank hospital to be seen. So can you just have an eye clinic at the church? And we're like, well, the NIH, according to the budget, says no, but we've asked the question. And so now we had to figure out how do we do this? And so we found some more money, and now we are in the place where we've purchased OCTs and autorefractors and all of the things so that we can at least do a really heavy duty screening of patients and then still, do the educational program so that we can get them to see the ophthalmologist. So the next step, which is where we are now, is actually implementing the program that we've designed with the input from the community. And perhaps more importantly, to evaluate this program along the way. So we want input in planning the program, but we also need to evaluate to make sure that it's still doing what we thought it was going to do, so that it is effective. It's not helpful to create these programs that sound good in our minds if they're not doing what we intend for them to do. So basically, the patients will come through, we'll take pictures, we'll do pressure, chemistry, all the things. And then the physicians or optometrists will review those data and determine who needs to be seen, glaucoma suspects or true glaucoma, and really any disease. Obviously, as a glaucoma specialist and from a NIH perspective, you have to narrow down on one specific disease, but really this is all comers. So we're taking fundus photos. If you have diabetic retinopathy, we get you to the right place. If you have macular degeneration or whatever it is, pterygium, we get you to the right place. And then the people who are identified as needing in-person care, that is when the community health worker enrolls those participants into combat glaucoma and starts the education journey with them and support program. But how do we sustain these things? So, we have mobile vans, we have these new programs popping up like this one, but when my grant is over, what will happen? And so that is really the concern. And I don't know the answer to that question, actually. But I do believe that when we include the community from the beginning, making sure that the program is desired and wanted from the community. And when we have the input of the people who are going to use it, I believe that it will be more effective. And if it's more effective, then we have good numbers to show people who may provide those funds, including local, state, and hopefully federal governments. One of my colleagues, Dr. Newman Casey, has some wonderful data on the study that we're working on through the CDC. And we are petitioning, the state of Michigan. We're saying like, hey, the prevalence of glaucoma is single digits, but we're finding 20 to 25% hit rate for glaucoma. And so this is meaningful work. And so, but we need your help. We need your help to keep this going and keep people from going blind. We start talking about numbers and lost productivity, and then they start to listen. So let's see. But sustainability is something that you have to think about from the inception of designing these programs, because it's really, sometimes it does more damage from a community relationship standpoint to start these programs. And then when the funding is up, you know, apologize profusely, but what can you do? You have to go. And sometimes that burns bridges. And when we talk about trust, it's a ding in that trust building relationship. So where do we go from here? A couple of years ago, I had the wonderful opportunity to participate, be a member of the task force, the AAO's task force on disparities in eye care. At the time, our president was the fabulous Dr. Tamara Fountain, and that committee, she and Dr. Paul Lee led. And there are 5 sub-task forces that were improving access to care, enhancing workforce diversity, patient education. We really wanted to talk about how we leverage data from all of these research studies. And then our main task from the AAO was to put out really a roadmap on what the AAO, its members, eye care providers all over the world can do to try and address some of these disparities. I know that you guys have, I think, read, Dr. Cower said that you guys have tapped into that paper. It's a long paper, but it can be divided into little bites. But we tried our best to really dig deeply and talk about all of the things that exist, disparities that exist, and more importantly, talk about some of the things that we thought might be ways to get us closer to equity. You already know this, but we divided the paper into 2 parts. Again, we talked about what exists now, the epidemiology of the disparities, and then a framework on how we can address some of these disparities. So there were probably 20 people on the total task force, but each sub-task force was divided into 5 or 6 people. So this was our team. Myself and Ann Coleman led the way. Elise Mike, the first person there, is a resident at Wilmer. Victoria Sang is a glaucoma specialist at UCLA. Tanya Rodriguez is a medical student at Wayne State. Alexis Warren is now retina in Chicago, and yours truly. One of the things that was really important to us was to really try to infuse the importance of social determinants of health throughout the paper. Because, as we talked about earlier, we can't do it alone. So studies show that a population's health is determined by 80% of a population's health is determined by social determinants. And so that only leaves 10 to 20% of the excellent work that we do that will make our patients' lives better. So we can try our very hardest, and we do that. But we really have to start to think about how we can, and you guys are already thinking about how we incorporate other sectors, other healthcare providers into our practice so that we can really start to address the whole patient. Really, we think that we are, but we don't have time. And there are questions, things that may be affecting the way that a patient is responding to us or responding to the suggestions that we make that we just don't have time to tap into. And so it really is a great opportunity for us to partner with other sectors. And not just sectors within the healthcare space, but I mean zooming way out and thinking about, from a macro standpoint, some of these structural things that we should be thinking about. So governance, economics, all of these things are impacting the way that we are allowed to take care of patients. They impact the treatment that patients are allowed to receive. I mean, all of these things we have to start thinking about. And if we don't have time to think about them, then we should at least incorporate other people into our practices that have time to think about those things. We often think about the health and well-being of the single patient. We're starting to think about those social determinants, but really thinking about the structural things, I think, is that next level. It's really difficult to do, feels overwhelming, but it's something that we have to think about. With regards to social determinants, so for example, when we think about the environment, that can certainly impact our eye care. I mean, there are studies in human models and animal models that show how particulate matter affects ocular hypertension and glaucoma. And so, and who is disproportionately affected by this particulate matter? People of color in the United States. And so this is not just a coincidence. These are things that have to do with policies and rulings, or where do the landfills go? Where in Detroit, on southwest Detroit, which is a part of Detroit that is heavily populated by people of Latinx descent, that is where the Marathon Oil Refinery lives. And I mean, I don't even like to drive by it. Imagine living there, you know, the levels of asthma and other diseases that can be associated with bad air that you're breathing every day. I mean, those people live there every day, and those are things that we may not think about, but those aren't coincidences. Those are things that partnering with our governments and things, we can do things about that. So it feels overwhelming. There are some days where I'm just like, what is the point of any of this? We know it's bad. It's not going to be fixed. We've known it's bad. Maybe I should just go make lots of money and travel to Zanzibar every couple of months. But, you know, no one can do everything, but everybody can do something. And I am certain of that. Where do we start? First, we have to just acknowledge some of these systemic things that are contributing to the disparities. So 2020, 2021, the AMA put out this statement about acknowledging the effects of systemic racism on health and healthcare. I think we have done a good job of that, but it's important to keep in the back of our minds when we're thinking about how we interact with our patients. And it's not just racism. There are plenty of other structural isms. We still deal with, you know, we see papers in JAMA and all the time about how women ophthalmologists or women trainees are paid or differently or trained differently, all of these things. So sexism is still a thing. Classism certainly is a thing. Homophobia, xenophobia, all of these things are things that we have to think about. And we don't think about oftentimes the divide between urban areas and rural areas, but there certainly is. As someone who spent the latter half of my childhood in a rural area, I have seen how people from rural areas are left out. And even if they aren't, they certainly feel left out. So those are things that we need to consider when we are taking care of our patients, and some of the things that they may come in with. We have to think about those things. And anytime I start to think about isms, I feel the air being sucked out of the room and people get really tense, but I promise I'm not talking about the things that we are doing to each other. I'm not talking about the interpersonal isms. I genuinely think that most of us are really good people and want to do good work and do good work. I'm talking about the systemic, the structural things that no one is doing, but just are. We are just operating in this space of isms, and we have to do our best to try to mitigate those. We can all examine how our biases might affect patient care. We all have biases. There's no way to avoid it. Developing biases is probably good for our safety. It's how we learn to stay away from some things and go towards some things. So we all have them. We just have to acknowledge that and think about how our biases may be affecting our patient care. And we can do that by reviewing our clinical practice data. You guys have already done that. I mean, to see those data up on the screen with the resident clinic and now the urgent clinic, I mean, those are the types of things that we need to do to really self-reflect on what we are doing as an individual practice or perhaps as a department. These are things that we need to do. Increasing community engagement. You know, we all operate within a community, and trying to be part of that community, I think, is important, and certainly in building that trust. There have been, I don't know how things are here in Rochester, but I know when I was in medical school in Durham, North Carolina, there was this huge thing between the people who lived in Durham and the people who worked at Duke. As if they, we didn't live there too, but the Durhamites certainly didn't feel that way. There was this thing where, we were within our little ivory tower and we didn't really care about the community. And some of that may be warranted based on how people were treated when they stepped inside of those walls. And so trying to be out in the community a little bit more, I think is helpful. And it doesn't have to be difficult. There are community centers and churches who would love to have someone come and just talk about what is glaucoma. I didn't know that diabetes can, make me go blind. Like, I would love to hear something about that. So just little things like that help to build trust and then get people in to be seen sooner. Back when I was a medical student, I went out to churches and housing projects, and I just sat down with people and asked them, like, well, what can we do? What is it that we can do to keep people from going blind? And they said, we just need more doctors in our community. We don't feel comfortable coming there. Can you come to us? And that's easier said than done. I fully acknowledge that as I'm trying to start this program at the church, but there are ways, and I know you guys have 10 satellites, I think. So, I mean, obviously, we're all doing our best to get out to meet patients where they are. There are ways that we can do that even more. And certainly continuing our research efforts in the community is important. I don't have to talk about increasing diversity in ophthalmology. A couple of years ago, there was a paper out of Yale that talked about how ophthalmology departments were the third least diverse amongst medical schools. I think the worst was radiology, then orthopedic surgery, and then us. So again, the AAO, the AUPO, all of our respective society organizations have really done a wonderful job in trying to increase that diversity. But there's always room for improvement. So the good news is that we're trying, I think that is great. How do we do that? So we need to foster an inclusive environment. So one thing that I'm always really afraid of is us recruiting diverse applicants to a space that is not warm and welcoming for them. So that is, we want diversity, but we also want inclusion. So we need to make sure that as we are recruiting diverse applicants, we are also making sure that they are not walking into a load of trauma. We want their experience to be the same as everyone else's. And so making sure that we are recruiting and retaining diverse applicants is really important. And then there are all of these pipeline initiatives through our subspecialty organizations and maybe even locally that are really helpful. And then advocacy. I don't know how active you guys are, how many of you go to the mid-year forum? Anyone? Mid-year forum? Yeah. So that is, our state societies are a wonderful place. Our local ophthalmology societies are a wonderful place for advocacy. So that is a great way to advocate for appropriate insurance coverage. Some of the ways that we are not able to take care of our patients is because of what insurance covers, and that is a shame. And I believe that as physicians, we can and should be leading the way, as opposed to people who don't know anything about medicine telling us how to take care of our patients. So that is certainly, if you can't do any of the other things, you can certainly, go to when you have the state legislature day, or whatever it's called here, state advocacy day, go and talk to your representative about the challenges that we have taking care of our patients, and try to get some legislature passed that will help not only us as a field, but also help our patients. And I mean, next week, everybody can vote. So we don't think about these things, but it really is true that we have voices. There are things that we can do. So we all have an opportunity to do something to impact health equity. So many things to do. Again, on this list, I'm sure you can find one thing that you can do to try and move the field forward. Getting to health equity, I believe, is a team sport. We need all hands on deck. There's room for everyone. So it's not one of those things where, oh, she does health equity, so I need to do something else. No, there's plenty of room and plenty of work to go around. So I'm looking forward to partnering with all of you to move our field forward closer toward equity. Thank you so much for having me, and I'm happy to take any questions.
Absolutely phenomenal.
Thank you.
That really rings true with us here in Rochester. And I'd like to start with the first question. So, talking about, kind of acknowledging structural racism and in the practice of medicine. And I think one of the hardest things has been to open this discussion about resident clinics.
Yeah.
And while not intentional, people are very sensitive to what's been going on and almost don't want to admit to themselves that there's a problem, right? So how do you engage in a conversation? And at the AUPO, we meet these people. Sometimes we see them on committees and other things, but we really don't have a trusting relationship to have. So these conversations are often very closed conversations and very protected opinions are. So how do we do a better job of opening up that conversation and creating that dialogue?
I think, in my experience, the best way is to really focus on the fact that these are structural things, and we're not people. When you start to talk about these things, people instantly feel like, not me.
Yeah.
I don't do that. But we're not talking about interpersonal isms. We're talking about this system in which we operate. No one, I doubt, no one said, oh, Black patients, send them to resident clinic. Residents, no one said that, but somehow that happened. And this is the system in which we operate. Perhaps it's an insurance thing, but if Black and brown and poor people are disproportionately on Medicaid, then who ends up in the residence clinic? So it's not this intentional thing. So I think if we can zoom out and take it out of the, I'm talking to you, we're not talking about you as an individual. We're talking about a system in which we operate. I think that at least lets people's shoulders relax and start to hear. Because I think what happens is when we start talking about these things, people immediately get defensive because they're assuming that we're talking about you as an individual, but perhaps we're not. We're talking about the system.
Yeah, I loved your slide with the iceberg. And I gave a talk I do a lot of transportation equity. I'm an ophthalmologist, but I'm from Portland, Oregon, so I like biking.
Oh, yeah.
Blah, blah, blah. Some of the people, these guys all know I do a lot of biking. So, and I gave a talk at our annual meeting, the state meeting, and I started looking at, I've been looking at the transportation issue, and the low-income BIPOC communities are underfunded in terms of just systemically underfunded.
Mm-hmm.
But there's an amazing graphic, if you ever get a chance to see it. It's put out by Urbana 2. It's a research group that looks at creating equity in urban development. And it basically shows that where the wealth is coming from for city governments and municipalities. And it turns out you'll probably see this at some point, but it's like a three-dimensional map showing where the money's coming from. And it turns out that the money actually is coming from those Hyatt hotels and the downtown area. You see a big spike there, but the other place that it comes from is from low-income communities. Actually, they're actually funding the wealth of a municipal government is actually coming from there. In the suburbs, nothing against the suburbs, a lot of ophthalmologists live in the suburbs, but the suburbs are actually underfunding their municipalities, which just kind of blows your mind. You'll see that they're on the low end of, they're actually underfunding. They're costing the municipalities basically because the farther you go out, the roads are expensive, the utilities, the infrastructure is expensive. Those low income more densely populated areas are actually much more productive in terms of wealth for municipalities, which kind of blew my mind. But it kind of gives you, and yet we tend to fund, we're almost subsidizing the suburban populations at the expense of BIPOC communities, basically. Really interesting stuff. And, I think people are starting to look at that structural racism in a whole different way.
Yeah. In this conversation, we just had a book club. We just read Cast, so we just finished up our OEI conference for the university. It was about 3 weeks ago now. I think some of the book club members are here. But to your point, number one, it's you have to communicate with people that you're not pointing fingers, that you're not accusatory.
Yep.
And in the book, they have this metaphor talking about structural racism as a house that was built, and now there are people who are living in it. And some people are even in denial that they're living in this house. But again, we're not coming from a place where this is your fault. You did this. We're just trying to get you to acknowledge that you live in this house, that you live in this structure. Once you do that, I think it makes it a little bit easier. Some people you can convince, some people you may not convince. But our focus needs to be on the people that we can convince, that you do live in this house, that there are structural inequity, structural racism, and then you can take it from there.
Yeah, I loved your presentation and I love that approach to the problem. There's a segment of the population, and you can guess how we'll vote, that believe that you're poor, it's your problem. You are a person of color, or you're a person of this, or a person that, it's your problem. And that portion of the population is going to be resistant. It's not about pointing your finger at them. They don't even want to acknowledge the problem, right? Why should I spend my money to help you? You go get a job, right? How do you approach that?
Oh, man.
That's a tough one, right?
Just know the funds, my God. I don't know. I don't know. I think the more we can take the person out of it, there are some people who are just not going to convince, and I don't know. There are books written, I mean, you can go back to, the 1800s and talk about how race is a total made up fallacy, and people will still believe that Black people experience pain differently or their brains are smaller. I mean, you can go back and show people the data and they still won't believe it. And so I don't know how you get to those people. I don't know.
So I have a comment on that, actually. Going back to the OEI conference, we had, one of the speakers were 2 peacemakers. An individual from Palestine, individual from Israel. They have had really successful TED Talks, really successful speaker series. I went to dinner with them, and then we also had some community people at the dinner. And one of the women, her name was I think Kat or Chris. She's actually part of a white accountability group. We went around the table, introduced ourselves, where we were. And one of the things that really rang home with me is the fact that she acknowledges that she lives in this house. She acknowledges that there's structural racism, but she said that that group, like if people of color could have fixed the problem, it would have been fixed a long time ago. It has to do with your advocates. It has to do with people who are Caucasian. Again, acknowledging that you're in this house and speaking with other people who look like you to help them realize that they live in that house too. And it's not just up to us. So if you don't have those advocates, if you don't have these people who you're working with, then it's going to be damn near impossible for that message to come from us to bring home truth for them.
I also think it's part of the salmon swimming up the stream, right? If you are disadvantaged in your life in whatever way, by your gender, by your race, by whatever, you are swimming uphill, right? That's the house. And I think getting people to understand that the further down you are down the stream, the harder it is to swim upstream.
Sure.
And someone's got to be there to help you.
Sure.
And until we have advocates to help these people, whoever they may be, get upstream, it's not going to be fixed.
Sure.
and it's just gonna draw society down and make society more divisive and make more problems. And it's not gonna help the wealthier get wealthy. It's not gonna help anyone.
I think, on the one hand, the way that we make it easier to discuss these things is by zooming out and not focusing on the individual. But I think perhaps the way to fix it is by bringing back that interpersonal relationship. So, there may be people who, live in, I don't want to call out places because I'm like, who knows where people are from, but let's say they have never interacted or never gone to school with a person of Muslim faith. And all they see is what's on the news, and they associate being Muslim with 9/11. These are the way that some people may think if you have never interacted with a person, a real life human. And so if we can, I've seen stories where you build friendships with this individual. And then it's like, oh, I didn't realize that Muslim people are lovely, but it's about the human touch, really. And I don't know.
People, not politics.
Yeah, and I don't know how do we do that? But that's what we need.
And that reminds me
Love in the world.
of a quote from Trevor Noah, the comedian who used to do the Daily Show. He says in one of his books that travel is the antidote to ignorance. If you don't leave your backyard, if you don't leave your block, if you don't leave your county, then you're going to eat up everything that the media is serving.
Yeah.
Right.
Yeah. Dr. Alice.
Yeah, I also think that the way things are right now, there's a lot of people that are benefiting from it. So some people do not want it to change. And I think that's the reason that we're having so much conflict right now, because there's a whole set of people that benefit, and they feel like if they bring other people in, whether it's through diversity, equity, whatever way you want to use it, they think that they're going to lose their position. And they don't realize that there's enough for everybody.
Yeah.
So I think that's one of the big things that we have to acknowledge. And I think the way the system is set up, and I'm going to just use this country as an example, over 250 years, a lot of the things are so tightly structured that it's going to take a lot to remove them. But there's a set of people that are benefiting that have the power to create some of these changes, and a lot of them don't want to because they're going to lose their position and some of the benefits that they have acquired.
There's a way to talk about and it's science that diversity improves the situation for everyone. So, thinking about things from that aspect, I think may be helpful. Again, there are some people who are just, you're never gonna reach, so.
Do you have any advice for specifically young physicians who maybe
not a young person.
maybe like they know that their personal ethic is in the right place, or their politics are in the right place, or their human interaction is in the right place, but they wonder about their ability to find time and money in the future to be able to pursue projects like this or affect a change that's bigger than just them and their patient.
Yeah.
It seems like you were able to get funding from the NIH in order to do your project, which is amazing. What advice and what brought you there recently?
Come work for me.
Yeah. That's a tough one because I have been talking about the same stuff since I was a medical student, and it took a long time to get my work funded. And so it's only been, I would say, in the last 10 or so years that we've really, the big funders, the NIH, the CDC, have really started to really, really fund, not just a couple pennies here and there, but actually multi-million-dollar towards funding this grant. So I will not lie and say that if you are interested in doing health equity or health disparities work, that that it will be as plentiful as far as funding as maybe basic science or translational research. But we're in a time where I think maybe we were in a time a few years ago and now it's dwindling, but I think we're still in a time where people have been awakened and there are institutions and funders who really want to see this type of work continue. So it doesn't have, I certainly didn't start out with $1 million grant. It started out with me being a medical student and Dr. Lee saying, buy a fruit tray and some snacks and go out and ask people questions. And that's what I did. And, that's how it started. And so, it wouldn't cost you much of anything to go to a local church and or a synagogue or a mosque or whatever, and talk about the eye disease of your choice. And that's how things start. We give information, and while we're giving information, we can be collecting data. And that can be the pilot study that you use to then create this other big, resident project. So, it just starts with the desire to do good. And then from there, it may take a little while, but eventually, you'll continue to do great work. So if you're interested, I'm happy to chat, but you just have to start somewhere,
All right, well, thank you so much. And lastly, I would just like to present this to you, Dr. Elam, to commemorate your visit here and what a wonderful talk you